Good morning, ladies and gentlemen, esteemed guests, and students in New Hampshire. My name is Kwame Ocran, and I'm a rising junior at Brooklyn Technical High School. This summer, I began work at the SUNY Downstate Medical Center in partnership with the Arthur Ashe Institute for Urban Health. And I worked under the apprenticeship of Dr. Tracy Wilson and Dr. Michael Joseph. There, we began work on barbershops as behavioral settings for HIV prevention targeting African American heterosexual men. So, without further introduction, let us begin. So, I'm going to begin with giving you some facts about HIV and African Americans. HIV and AIDS disproportionately burden persons of African ancestry. Although African Americans make up only 13% of the United States population, they accounted for the majority of reported cases of HIV and AIDS between the years of 2001 and 2004. In 2004, the rate of HIV diagnosis was over 8 times higher in persons classified as black as compared to persons classified as white. Also, this prevalence is shown in other diseases. For example, rates of gonorrhea infection among black Americans were 20 times higher than the rates of white Americans. Okay, so what happened was there was a call for some kind of reform in this kind of society. So the Center of Disease Control released a request for proposals where different facilities would try to propose some kind of way to address this issue. Where will we attack this issue? As you can see, the total amount of HIV diagnosis in central Brooklyn is more than the entire borough of Brooklyn and New York City. The percentage of HIV diagnosed with AIDS at the same time is higher than any other area, as you can see in this table. And the people living with AIDS within a 1,000 person population of people ages 13 and over was double that of the borough of Brooklyn. So our objectives were to conduct research necessary to form an intervention. An intervention is defined as an effort to promote good health behavior or prevent bad health behavior. And we also wanted to create something that was culturally sound, that used the normal conventions of society associated with African Americans. And another objective we had was to identify the HIV heterosexual transmission risk behaviors among African American men. What did these individuals engage in during sexual activity that caused them to have a greater increase in HIV diagnosis as compared to other populations? We also wanted to examine individual and contextual factors that predict variation in these behaviors. We wanted to know what was different about these populations than compared to other populations as well. Okay. So we had 3 main hypotheses. First, what are the factors associated with high-risk sexual behavior among African American men approached? We wanted to know what kind of behaviors they engaged in, if it meant unrestricted condom use, multiple partners, things of that nature. We wanted to also know what did the participants believe are proper intervention methods for HIV. One example of this belief might be if the sexual act is engaged while standing up, the person can't transmit HIV, which we all know is completely wrong. And we also wanted to know what are acceptable and effective interventions for reducing risk behaviors amongst African American men approach. So we're doing all the things that we're doing in the actual study, only to a scaled down version. First, we'll do a client brief risk assessment survey. And this assessment survey contains questions that were developed to describe the population of men who receive services at barbershop within our target neighborhoods. What this means is that the topics explored during our survey would include, but are not limited to, sexual behaviors and risk behaviors, history of arrest and jail time, living situations, perceived availability of proper food and shelter, alcohol and drug use, and HIV testing history. Next, we would also use client focus groups. Although these different phases of the methodology occur at the same time, the focus group is the most important because they are related to the other parts of our methodology. During our focus groups, we'd be able to cover topics such as masculinity, gender role and conflict and strain, types of sexual partners, partner selection and networks, sexual risk behaviors with different partner types. A focus group, as you can see below, is a form of research where people are asked about an attitude and how they respond. Also, we'll take individual clients from each focus group and have an in-depth interview with them. where we'll act the same as the focus group, only we'll figure out the factors between the individuals. Also, we'll cover barber personnel and focus groups, because we also need the barber personnel in each barbershop to comply with our research, because they are crucial to letting us talk to the patrons and to them themselves. Once we collect this data, we can effectively change our intervention and implement it in a way that they can understand and use. So this is the proposed timeline of the study. After the pilot work, we'll try to get approval by December 2008, and then we'll conduct the first parts of the methodology, as you can see. After that, we'll analyze this data and develop the intervention. And then we'll conduct the component testing to modify our intervention and finalize it by January 2009.